Bismillahirrahmanirrahim. Treatment or management of hyperventilation syndrome. Because respiratory distress or chest pain has many potentially serious causes, the diagnosis of hyperventilation should never be made in the field, and even when a patient with this complaint carries a prior diagnosis of hyperventilation syndrome, he or she must still be transported to a hospital for a more complete evaluation. All the recommendations to rebreathe into a bag paper have not stood the test of time and are rather impractical in the middle of a supermarket. Because of cold breaths often accompany an episode, that's to say vasoconstriction, placing the cold palms the, onto the checks can help suppress the desire to breathe, thought to be related to diving the reflex. Again, this is an untested remedy. There are some breathing techniques after after exclusion of life-threatening conditions, simple reassurance, and an explanation of how hyperventilation produces the patient's symptoms are usually sufficient to terminate the episode. Provoking the symptoms by having the patient voluntarily hyperventilate for 3 to 4 minutes often convinces the patient of the diagnosis, but it's time consuming and may be ineffective. And most patients with hyperventilation syndrome tend to breathe with the upper thorax and have the hyperinflated lungs throughout the respiratory cycle. Because of the residual lung volume is high, they are unable to achieve full tidal volume and experience dyspnea. Diaphragmatic breathing slows the respiratory rate, gives patients a distracting maneuvers to perform when attack occur, and provides patients with a sense of self-control during episodes of hyperventilation. And this technique has been shown to be very effective in a high proportion of patients with hyperventilation syndrome. Physically compressing the upper thorax and having patients exhale maximally decrease the hyperventilation of the lungs. Instructing the patient to breathe abdominally using the diaphragm more than the, more than the chest wall often leads to improvement in subjective dyspnea and eventually corrects the many of associated symptoms. Medications in hyperventilation syndrome. Several medications, including benzodiazepine and selective serotonin reuptake inhibitors, have been employed to reduce the frequency and severity of the episode of hyperventilation, and these agents require prolonged use and are best managed by a consultant on an ongoing outpatient basis rather than through sporadic prescriptions after an ER visit. And use of benzodiazepine for stress relief and for resetting the trigger of hyperventilation is effective, but again, the patient may require prolonged treatment. Although acute chemical sedation may be effective and humane in selected severe cases, prolonged use of this medication should not be initiated in the ER. Stress reduction therapy, administration of beta blockers, and breathing retraining have all proved effective in reducing the intensity and the frequency of episodes of hyperventilation. If the diagnosis of hyperventilation syndrome has been established, the patient should be referred to an appropriate therapist to implement these techniques over the long term. The prognosis of hyperventilation syndrome. Some patients improve quickly with explanation, and some tend to replace a time of stress. Some patients tend to relapse at time of stress. Some prove resistant to any treatment and probably should be seen in the clinic regularly but infrequently to reduce their likelihood of involving other medical services with another pointless round of investigations. That's all, and thank you.